This conference will now be recorded.
I know Matt said he's having trouble hearing me. Anybody else? Give me a thumbs up if you can hear me okay. All right. All right, so we're going to talk about shock or hypoperfusion. This is defined as inadequate cellular perfusion, and any compromise in perfusion can lead to cellular injury or death. So diffusion is a passive process in which molecules move from an area with higher concentration of molecules to an area of lower concentration of molecules. This is how oxygen and carbon dioxide cross the walls of the alveoli. The majority of oxygen is carried to the tissues attached to hemoglobin. Carbon dioxide can be transported in the blood from tissues back to the lungs in three different ways. It can be dissolved in the plasma, it can be combined with water in the form of bicarbonate, or it can be attached to hemoglobin. Carbon dioxide waste products released from the cells can combine with water in the bloodstream and then form the bicarbonate. Once it reaches the lungs, the bicarbonate breaks back down into carbon dioxide and water, and the carbon dioxide is exhaled. In cases of poor perfusion or shock, the transportation of carbon dioxide out of the tissues will become impaired, resulting in a dangerous buildup of waste products, which may cause cellular damage. Shock refers to a state of collapse and failure of the cardiovascular system that leads to inadequate circulation. To protect your vital organs, the body directs blood flow from organs that are more tolerant of low blood flow, such as the skin and the intestines, to organs that cannot tolerate the low blood flow, such as the heart, brain, and lungs. Early recognition of the signs and symptoms of shock can save lives, and shock is life-threatening and requires immediate recognition and rapid treatment. Cardiovascular system has three parts. You've got your heart, which is the pump, your blood vessels, which are the container, and the blood, which is the content. There's a nice little diagram of the whole system working as a whole. The perfusion triangle. Uh, Basically, there's the three parts. The heart. Any damage to the heart that's caused by disease or injury decreases the ability to properly function as a pump. Therefore, it can't move enough blood through the body to support perfusion. The blood vessels, if they all dilate rapidly, the normal amount of blood volume is not enough to fill the system and provide adequate perfusion out to the body. And then the blood itself, if there's not enough blood or if you have plasma loss, the volume of the fluid in the container is not enough to support the perfusion needs of the body. So your blood pressure is the pressure of the blood within the vessels at any moment in time. The systolic blood pressure is the peak arterial pressure, or the pressure generated every time the heart contracts. The diastolic pressure is the pressure maintained within the arteries while the heart rests in between your heartbeats. And for the blood pressure, it is listed like that. The systolic is the top number, the diastolic is the bottom number. The pulse pressure is the difference between the systolic and the diastolic pressures. Um, Systolic subtracted from diastolic is your pulse pressure. Your pulse pressure signifies the amount of force that the heart generates with each contraction, and a pulse pressure less than 25 millimeters of mercury may be seen in patients that are in shock. Blood flow through the capillary beds is regulated by the capillary sphincters. Um, and the capillary sphincters are circular muscular walls that constrict and dilate. These sphincters are under control of the autonomic nervous system, which regulates your involuntary functions such as sweating and digestion. And your capillary sphincters also respond to other stimuli like hot, cold, the need for oxygen, or the need for waste removal. Regulation of your blood flow is determined by cellular needs. For good perfusion, you've also got to have good oxygen exchange in your lungs. You've got to have nutrients in the form of glucose in your blood, and you've got to have a good waste removal primarily through the lungs, so primarily breathing out that carbon dioxide. Mechanisms are in place to help support the respiratory and cardiovascular systems when the need for perfusion of vital organs is increased. And that includes your autonomic nervous system and hormones. The sympathetic side of the autonomic nervous system, which is responsible for your fight or flight response, will assume more control of the body's functions during a state of shock. Um, this response causes a release of hormones such as epinephrine and norepinephrine. Hormones cause an increase in heart rate and in the strength of cardiac contractions, as well as vasoconstriction in non essential areas, primarily in the skin and the GI tract. This response causes all of the signs and symptoms of shock in the patient. So there's many different types of shock that result from three basic causes: pump failure, poor vessel function, and low fluid volume. So here you can see the first cause, pump failure. It can be caused by heart attacks, trauma to the heart, or obstructive causes like a large pulmonary embolus. Low fluid volume can be caused by trauma to the vessels or tissues, fluid loss from the GI tract, such as vomiting or diarrhea, and it can also lower the fluid component of the blood. Poor vessel function can be caused by infection, drug overdose, spinal cord injury, or anaphylaxis. So here's a table showing the cause and the type of shock. So when you have a pump failure, we're talking about cardiogenic shock and obstructive shock. Um, Tension pneumothorax, cardiac tamponade, and pulmonary embolism can be the causes there. Poor vessel function, that's distributive shock, which is also represented by the septic shock, neurogenic shock, anaphylactic shock, or psychogenic shock. Low fluid volume is called hypovolemic shock, and that kind of comes off into hemorrhagic shock and non-hemorrhagic shock. Cardiogenic shock. All right, cardiogenic shock is caused by inadequate function of the heart or pump failure. A major effect is the backup of blood into the pulmonary vessels, and the resulting buildup of pulmonary fluid is called pulmonary edema. Cardiogenic shock develops when the heart cannot maintain sufficient output to meet the demands of the body. Cardiac output is the volume of blood that the heart can pump per minute, and it's dependent on several factors. The heart must have adequate strength, which is largely determined by the ability of the heart muscle to contract. The heart muscle must receive adequate blood to pump, which is called your preload. And the resistance to flow in the peripheral circulation must be appropriate, which is called your afterload. Obstructive shock is caused by a mechanical obstruction that prevents an adequate volume of blood from filling the heart chambers. Three most common examples are your cardiac tamponade, your tension pneumothorax, or a pulmonary embolism. Cardiac tamponade or pericardial tamponade is a collection of fluid between the pericardial sac and the myocardium. Um, if the effusion becomes large enough, it can prevent the ventricles from filling with blood, which is a condition called cardiac tamponade. It can be caused by blunt or penetrating trauma that causes hemorrhage around the heart. And the signs and symptoms of cardiac tamponade are referred to as the Beck's triad. That's an important test question right there, Beck's triad. The three things you're looking for in Beck's triad are going to be the presence of jugular vein distension. So you're going to see the jugular veins in the neck become very distended, muffled heart sounds, and narrowing pulse pressures. And that's where the systolic and your diastolic blood pressures start to come closer together. Tension pneumothorax. This is caused by damage to the lung tissue. Air that's normally held within the lung escapes out into the chest cavity. Um, the lung will collapse, and if the pneumothorax is left untreated, the air is going to accumulate in the chest cavity and it's going to apply pressure to the other organs, including the heart and the great vessels. A pulmonary embolism is a blood clot that occurs in the pulmonary circulation that blocks the flow of blood through the pulmonary vessels. When a massive pulmonary embolism occurs, it can prevent blood from being pumped from the right side of the heart to the left, resulting in a complete backup of blood in the right ventricle, which leads to catastrophic obstructive shock and complete pump failure. Distributive shock. It happens when there's widespread dilation of your small arterioles, small venules, or both. The circulating blood volume pools in the expanded vascular beds and tissue perfusion decreases. Septic shock occurs as a result of a severe infection, usually bacterial, in which toxins are generated by the bacteria or infected body tissues. Widespread dilation of the vessels combined with plasma loss through the injured vessel walls result in the shock. And like I said, the widespread dilation of all the vessels with the plasma loss is what gives you your septic shock. Neurogenic shock is usually the result of a high spinal cord injury. Muscles in the walls of the blood vessels are cut off from the sympathetic nervous system and nerve impulses that cause them to contract. All vessels below the level of the spinal cord injury will dilate widely, increasing the size and capacity of the vascular system, which causes the blood to pool. Anaphylactic shock occurs when a person reacts violently to a substance to which he or she has been sensitized. Sensitization means becoming sensitive to a substance that did not initially cause a reaction. Each subsequent exposure after sensitization tends to produce a more severe reaction. So you look at some of the signs and symptoms of anaphylactic shock. On the skin, you're going to see flushed, itchy, or burning, especially over the face and upper part of the chest. You're going to see urticaria or hives, which are going to spread over the large areas of the body. Edema, especially in the face, tongue, and lips. Pallor, cyanosis, or the bluing, the blue sensation around the mouth. Circulatory system, you're going to see dilated peripheral blood vessels, increased vessel permeability, a drop in blood pressure, and a weak, barely palpable pulse. Respiratory system, sneezing or itching in the nasal passages. You're going to hear stridor. It's going to sound like an upper airway obstruction. They might experience tightness in the chest with a persistent dry cough. You're going to hear wheezing, and they're going to have shortness of breath. Secretions of fluid and mucus into the bronchial passages, alveoli, and lung tissue, which cause the coughing. Constriction of the bronchi. difficulty drawing air into the lungs, forced expiration requiring exertion and accompanied by wheezing, and ultimately cessation of breathing or the absence of breathing. They might also have abdominal cramping, nausea, vomiting, altered mental status, dizziness. They might faint or they might appear to be in a coma. Psychogenic shock is caused by a sudden reaction of the nervous system, and it produces a temporary generalized vascular dilation, resulting in syncope. Some of the life-threatening causes of psychogenic shock include irregular heartbeats and brain aneurysms. And the non-life-threatening events could be the receipt of bad news, experiencing fear or unpleasant sights such as blood. Hypovolemic shock. This is the inadequate amount of fluid or volume in the circulatory system. Um, it can be caused by hemorrhage and it can be caused by things other than a hemorrhage. This will occur with severe thermal burns as you lose some of the plasma and such from your blood volume. So some different stages as you go through the progression of shock. Compensated shock is the first. Then we move into decompensated shock. Um, decompensated is when they stop compensating. You're gonna see the blood pressure start to fall. And when shock has gotten too far, it's irreversible. And there's really no way to assess when your patient has reached that point, which is why we always recognize and treat the shock early, well before the patient gets to the point of decompensated shock. Signs and symptoms of compensated shock: agitation, anxiety, restlessness, feeling of impending doom. So that's your patient saying, I'm going to die. I feel like I'm going to die. Weak, rapid, or thready pulse, clammy skin, which is your pale, cool, and moist skin, pallor with cyanosis around the lips, shallow, rapid breathing, nausea or vomiting. Their capillary refill is going to be longer than 2 seconds, especially for infants and children. They're going to be very thirsty, and you're going to see that narrowing pulse pressure, or the top and bottom numbers on your blood pressure coming closer together. Once they get the point of decompensated shock, their blood pressure is going to start to fall. Their systolic blood pressure is going to be 90 or lower for an adult. Excuse me. Their mental status is going to begin to decline. They're going to become altered. Labored or irregular breathing. Their skin's going to become ashen, mottled, or cyanotic. Their pulses are going to be thready or absent. Their eyes will become dull and their pupils will dilate, and they'll experience poor urinary output. The blood pressure may be the last measurable factor to change shock. Um, when you start to see the drop in blood pressure, the shock has become well developed. Especially true in infants and children who can maintain their blood pressure until they have blood loss that is more than half of their total blood volume. By the time blood pressure drops in infant and children who are in shock, they're close to death. Expect shock in many different emergency medical situations. You should expect shock if a patient has any of the following conditions: multiple fractures, abdominal or chest injuries, spinal injuries, severe infections, a major heart attack, or anaphylaxis. For scene size up, you're going to want to be alert to the ultimate safety of your scene. You're going to want to make sure you wear your BSI, and you're going to want to determine what the mechanism of the injury or the nature of the illness is going to be. Your primary assessment for a patient with shock, um, it's going to involve a rapid exam to determine their level of consciousness, identify and manage any life-threatening conditions that they're found to have, such as serious bleeds. And you're going to determine the priority of the patient and transport them. A patient with a massive hemorrhage may require a tourniquet or direct pressure dressings when tourniquets aren't feasible before you open the airway. And that's where, when we talked about patient assessment, we talked about ABC versus CAB. If the patient's hemorrhaging and you're worried more about their airway, it's awesome that you open their airway, but if they have no blood to circulate, they're not going to survive that. You have to treat the most life threatening condition first. Your primary assessment, you should provide high flow oxygen to assist in their perfusion. Um, for hypoperfusion, treat aggressively, provide rapid transport, and always request ALS for these patients. So you're going to form your general impression of the patient. You're going to determine the need for any spinal stabilization and assess their level of consciousness. For their airway and their breathing, you want to assess their airway and just make sure it's patent. Quickly assess their breathing. On their circulation, you want to check their skin color, temperature, and condition. And you want to, again, check for any major bleeds. Check for distal pulses. If there are no distal pulses, check for a central pulse. You want to determine if that pulse is fast, slow, weak, strong, or altogether absent. A rapid pulse is going to suggest compensated shock. Um, Also, for compensated shock, the skin might look or might feel cool, clammy, or ashen. If the patient has no pulse and is not breathing, begin CPR. Again, in any trauma patient, treat their bleeding immediately. You're going to want to determine whether the patient should be treated as a high priority if you need ALS and where you're going to transport to. After you've managed all your life threats, determine their chief complaint and obtain a sample history with relevant information. Your secondary assessment. So you're going to perform physical examinations, repeat all your primary assessments, and then follow it up with a focused assessment. Perform a secondary assessment of the entire body if your patient's a trauma patient with a significant mechanism of injury or multiple injuries. If your patient gives you a poor initial general impression, if you found problems in the primary assessment, if your patient has a medical problem but is not responsive, if your patient has problems that were not noted in the primary assessment. Your assessment should be performed quickly but thoroughly to make sure you don't miss any significant or life threatening problems or delayed needed care. Whether your examination is of the entire body or just one specific area, if a life threatening problem is found, treat it immediately. And then your next step is going to be your vital signs. Reassessment. I'm sure Kevin talked about this on Sunday. Reassessments for critical patients are how often? How often do we reassess critical patients? Anybody? All right, every 5 minutes. Every 5 minutes, you're going to want to be reassessing these patients. And when you're doing that, you're looking for changes in their vital signs. You're evaluating if your interventions have made any changes, if they're helping or if they're hurting. Reevaluating their chief complaint to see if anything's changed. Reevaluating their ABCs, make sure their airway is still open, they're still breathing adequately, and their circulation is still adequate. And you're evaluating their mental status. Make sure they're not becoming altered. Based on your assessment findings, you're going to determine what interventions you need to provide. You're going to want to focus on supporting the cardiovascular system and treat for shock early and aggressively by giving oxygen and keeping the patient warm. You must begin immediate treatment for shock as soon as you realize the condition exists. Follow your standard precautions. Control all obvious external bleeding. Make sure the patient's airway is open. And maintain inline stabilization for the spine if it's necessary. Check for breathing and a pulse rate. You're going to want to comfort, calm, and reassure the patient while maintaining the patient in the supine position. Should never allow your patients to eat or drink anything prior to being evaluated by a doctor. If spinal immobilization is indicated, splint the patient on a backboard. Remember, inadequate ventilation may be a major factor in the development of shock. Always give oxygen, assist their ventilations if you need it, and use airway control adjuncts as needed. To prevent the loss of body heat, place blankets under and over the patient, transport the patient, and treat additional injuries en route. Consider meeting up with ALS on the way. Consider air medical transport. Actually, accurately record the patient's vital signs approximately every 5 minutes throughout treatment and transport. All right, give me 1 second, guys. I'll be right back. All right, sorry about that. Treating cardiogenic shock. A patient who's in shock as a result of a heart attack simply cannot generate the necessary power to pump blood through the circulatory system. Usually, patients with cardiogenic shock don't have any injuries, but they may be having chest pain. Patients in cardiogenic shock should not receive nitroglycerin because, by definition, they're going to be hypotensive. Their blood pressure is going to be too low to allow for nitroglycerin. The signs and symptoms for cardiogenic shock: um, low blood pressure, a weak, irregular pulse, cyanosis around the lips and underneath the fingernails, anxiety, and nausea. Ways to treat cardiogenic shock: place the patient in a position that eases breathing as you give them high flow oxygen. Assist their ventilations if you need to, and initiate prompt transport. If you don't have ALS on scene with you, consider arranging for a rendezvous en route. Treating obstructive shock. So for cardiac tamponade, your goal is to increase their cardiac output. You're going to give high flow oxygen, and the real only definitive treatment for this is surgery. So getting them to the hospital is your priority here. For tension pneumothorax, administer high flow oxygen via a non-rebreathing mask early to prevent hypoxia. Um, Chest decompression is going to be required to relieve the pressure in the chest, and chest decompression is an ALS skill. You're going to need a paramedic to do this. However, you should not delay transport waiting for your paramedic to show up. Treating septic shock. The proper treatment of septic shock requires complex hospital management, including administration of antibiotics. The appropriate standard precautions should be used, and you should transport them as promptly as you can. Administer high flow oxygen during transport and support their ventilations as needed. Preserve their body heat, and you should notify a specialized sepsis team if available to meet the patient in the ED. Most of our hospitals in both Maine and New Hampshire will now take sepsis alerts. If you have a patient that meets this criteria, when you give your hospital call in, you can tell them I have a sepsis alert for you. That's going to allow them to prepare some specialized lab testing and some specialized equipment upon your arrival. Treating neurogenic shock. Um, your goals are going to be to obtain and maintain a proper airway, provide spinal immobilization if it's indicated, assist inadequate breathing as needed, conserve their body heat, and ensure the most effective circulation possible. Transport the patient promptly to a facility capable of managing their spinal injuries. Treating anaphylactic shock. The most effective treatment for a severe acute allergic reaction is to administer epinephrine by way of intramuscular injection. For a patient with anaphylaxis, they require immediate treatment. They're going to need high flow oxygen. You may need to assist their ventilations, and you need to try and figure out what caused the reaction and how they received it. Keep in mind that these start out mild and they rapidly worsen. Um, and because of the potential for airway compromise, you should always consider getting a paramedic for these calls. Treating psychogenic shock. In an uncomplicated case of fainting, once the patient collapses and becomes supine, circulation to the brain is restored and they'll eventually return to a normal state of functioning. Psychogenic shock can worsen other types of shock. If it appears the patient fell as a result of psychogenic shock, check for injuries, especially in elderly patients. If the patient reports that they're not able to walk after they fall, you should suspect that there's another problem, such as a head injury. Transport the patient promptly. Any patient with a loss of consciousness should be transported to the ED for evaluation, even if they're back to normal once you get there. Treating hypovolemic shock. Control all the obvious external bleeding. The best initial method to control external bleeding is direct pressure. If it's not controlled with direct pressure, move on to a tourniquet. Handle the patient gently and keep them warm. Recognize internal bleeding and provide aggressive general support. Secure and maintain an airway and provide respiratory support, including supplemental oxygen and, if needed, assist their ventilations. Transport them as rapidly as possible to the ED. Treating shock in older patients. Older patients generally have more serious complications than younger patients. Many older patients take numerous medications that could either mask or mimic the signs of shock. Treating a pediatric or geriatric patient in shock is no different than treating any other shock patient. Provide spinal stabilization if it's indicated. If it's not indicated, place them in a position of comfort. Control any life-threatening hemorrhages immediately with direct pressure or a tourniquet. Suction their airway as necessary, and provide high flow oxygen via a non-rebreathing mask. Try to maintain their body temperature and provide rapid transport. All right, we've reached our review. We covered a lot of stuff fast. Does anybody have any questions on what we've covered so far? Give me a thumbs up if you're good. All right. All right, let's go through the review. If you guys can answer in the chat like we normally do. The term shock is most accurately defined as what? Good. B. Um, Remember, shock is referring to a state of collapse and failure of the cardiovascular system or any one of its components. And ultimately, it leads to the inadequate perfusion of the body's cells and tissues. Anaphylactic shock is typically associated with what? Very good. A. Urticaria, which is also called hives. Signs of compensated shock include all of the following except remember the differentiation between compensated and decompensated shock. All right, very good. D. Once once you start to see their vitals changing, you know that they're no longer compensating. When treating a trauma patient who's in shock, the lowest priority should be given to what? Good. C. Potential causes of cardiogenic shock include all of the following except for what? Very good. C. 60-year-old woman presents with a blood pressure of 80/60, a pulse rate of 110, mottled skin, and a temperature of 103.9. She's most likely experiencing which type of shock? Very good. A. Septic shock. A patient with neurogenic shock would least likely to present with what? Very good. C. 20-year-old man was kicked numerous times in the abdomen during an assault. His abdomen is rigid and tender. His heart rate is 120 beats per minute, and his respirations are 30 breaths per minute. You should treat this patient for what? All right, so with this one, remember what chapter we're in. We're talking about shock here. So While he might have a ruptured spleen, ultimately what we're going to be looking for today is shock. We're going to want to treat for hypovolemic shock. 33-year-old woman presents with generalized rash, facial swelling, and hypotension approximately 10 minutes after being stung by a hornet. Her BP is 70/50 and her heart rate is 120 beats per minute. In addition to high flow oxygen, this patient is in most immediate need of what? All right, very good. A. This patient's in anaphylactic shock, and the only true way to treat that is going to be epinephrine. All the following are potential causes of impaired tissue perfusion, except for what? Very good. A. All right, that's the end of this chapter. We're going to do pharmacology, but let's take a 10-minute break. We'll be back at 7 o'clock.
This conference will now be recorded.
All right, we're going to go over pharmacology now. So medications are an important intervention that are available to you as an EMT. When they're used appropriately, medications may alleviate pain and improve a patient's condition. Failure to administer medication safely and competently can lead to a serious consequence for both the patient and the provider. And for the patient, it can be up to and including death. So, pharmacology is the science of drugs, including their ingredients, preparation, uses, and their actions on the body. A medication is a substance used to treat or prevent disease or relieve pain. The phrase pharmacodynamics is the process by which a medication works on the body. A medication can either produce an effect or block the receptors to prevent other chemicals or medications from binding. An agonist is a medication that causes stimulation of receptors. An antagonist is a medication that binds to a receptor and blocks other medications or chemicals from attaching. The dose is the amount of medication that is given, which can depend on the patient's weight, the patient's age, and the desired action of the medication. And the action is the therapeutic effect that a medication is expected to have on the body. So pharmacokinetics are the actions of the body upon the medication or chemical. The onset of the action is the time from the medication administration until the clinical effects begin to occur. The duration is the length of time that the clinical effects will persist. Elimination is how the medication or chemicals are removed from the body. And the peak is the point or period when the maximum clinical effect is achieved. Some of the factors that affect how a medication works can be the route of administration and the shock states. So indications are reasons or conditions for which a particular medication is given, and a contraindication is the situation in which a medication would either harm the patient or have no positive effect. So indication is when we use it, contraindication is when we do not. Um, there are absolute contraindications, which are situations in which a medication should never be given if the contraindication is present. And there are relative contraindications, which are situations in which the benefits of administering the drug would outweigh the risks. Adverse effects are any action of a medication other than the desired action. Unintended effects are effects that are undesirable but pose little risk to the patient. Untoward effects are effects that can be harmful to the patient. Medications have a couple different names. The generic name is a simple, clear, non-proprietary name. Generic names are not capitalized. An example of a generic is ibuprofen. The trade name is the brand name that a manufacturer gives to the drug. Trade names always begin with a capital letter, and a drug may have more than one trade name, for example, Tylenol. Prescription drugs are distributed only by pharmacists and require a physician's order. Over-the-counter drugs may be purchased directly without a prescription. And then obviously there's other kinds of drugs, recreational drugs like heroin, cocaine, marijuana, herbal remedies, enhancement drugs, vitamin supplements, and alternative medicines. Any medication that a patient takes can be pharmacologically active and can cause an effect. So we need to ask patients about any and all medications or drugs that they're taking. Um, sometimes patients might not be willing to tell us that they use marijuana or something like that. But that's where we have to make them feel comfortable. We have to explain to them why we're asking the question. We're not law enforcement. We're not looking to get them in trouble. But anything they took or use could affect how we treat them. Routes of administration. Enteral medications enter the body through the digestive system. They're often in a pill or liquid form, like cough medicine. Medications that are administered via this route tend to be absorbed slowly and are not commonly used in an emergency setting. Parenteral medications enter the body by some other means. They're often in liquid form, administered through needles or syringes. They're absorbed more quickly and offer a more predictable and measurable response. Absorption is the process by which medications travel through the body tissues to the bloodstream. Some of the common routes of administration are per rectum or PR. Um, this provides a reliable absorption. Um, it says easy to administer, but I tend to disagree with that. But anybody have any idea of a common medication that would be administered PR or per rectum? So one of the common things that you might see out in the field, patients that have a known seizure disorder are given rescue medications that are sometimes administered per rectum or PR. Another route of administration is oral or PO. Um, those can take as long as 1 hour for the absorption to occur. Intravenous or IV injection, fastest delivery but can't be used for all medications. Intraosseous or IO is into the bone. It reaches the bloodstream through the bone marrow, and it requires drilling a needle into the outer layer of the bone. Subcutaneous injection is beneath the skin, and it's an injection given into the fatty tissue between the skin and the muscle. And then intramuscular injection, or IM, is into the muscle. It's absorbed quickly, and not all medications can be administered by the IM route. Inhalation, it's breathed into the lungs. It gets absorbed into the bloodstream quickly. Um, could be an aerosol, a fine powder, or a spray. Sublingual, or SL, is under the tongue. It enters through the oral mucosa under the tongue, and it's absorbed into the bloodstream within minutes. Transcutaneous or transdermal is through the skin. This is typically a patch that goes on the skin, and it has a longer lasting effect than other routes. Intranasal, or IN, it's a relatively new format for medication delivery. The medication is pushed through a mucosal atomizer device, or an MAD, that aerosolizes the liquid for delivery into the nostril. Uh, this provides for a quick absorption. So this is a table just to show you the different routes and the rate of absorption. The form of a medication usually dictates the route of administration. The manufacturer will choose the form to ensure the proper rate, the proper timing of the medication's release into the bloodstream, and the effects on the target organs or body systems. Tablets and capsules. Most medications given by mouth are in tablet or capsule form. Capsules are gelatin shells filled with powder or liquid medication, and tablets often contain other materials that are mixed with the medication and then compressed. Solutions and suspensions. A solution is a liquid mixture of one or more substances that cannot be separated simply. Solutions can be given by almost any route. When given by mouth, solutions may be absorbed from the stomach fairly quickly because the medication is already dissolved. Many solutions can be given as IV, IM, or SC injections. A suspension is a mixture of finely ground particles that are distributed evenly throughout a liquid by shaking or stirring, but do not dissolve. Suspensions separate if they stand or are filtered, and it's important to shake or swirl a suspension before its administration. Metered dose inhalers. Liquids or solids that are broken into small enough droplets or particles that may be inhaled. The spray canister will direct the substance through the mouth and into the lungs. It delivers the same amount of medication each time it's used, and it's often used for respiratory illnesses such as asthma or emphysema. Topical medications include lotions, creams, or ointments. They're applied to the skin surface and they only affect that area. Some of the examples: a lotion could be a calamine lotion, a cream could be like a hydrocortisone cream, and then an ointment would be like a neosporin. Transcutaneous medications can also be referred to as transdermal medications. These are absorbed through the skin. Many of the transdermal medications have systemic or whole body effects. If you touch the medication with your skin, you're going to absorb it just like the patient would. Gels are semi-liquid and they're administered in capsules or through plastic tubes. One of the examples for that would be oral glucose for a patient with diabetes. Gases for inhalation. They're usually delivered through a non-rebreathing mask or a nasal cannula. Oxygen is our most commonly used gas form outside of the operating room. Some of the general steps to administer a medication. So medication should only be administered under the direction of online or offline medical direction, and you need to follow the rights of medication. Um, so this is very important. There's a table on the next slide that you'll be able to actually see this, but the medication rights, the first one is the right patient. You need to ensure the patient that needs the medication is the same person that receives the medication. So make sure you're giving it to the right person. Right medication and indication. Verify the proper medication and prescription. So make sure you're giving them the right medication for their condition. The right dose. You need to verify that you're giving them the right form and the right dose of the medication. The right route. You need to give it via the right route. The right time. You want to check the expiration date and the condition of the medication. Right education. Inform the patient of the medication that you intend to administer, including any likely adverse effects or unusual sensations they might experience. The right to refuse. Patients that have decision-making capacity can decline or refuse proposed interventions or medications. The right response and evaluation. Monitor the patient's vital signs, mental status, signs of perfusion, and respiratory effort after you give a medication. Assess them for the anticipated response and observed for any adverse medication effects. The right documentation. Document your actions and the patient's response. And then medication cross checks. Use a verbal cross check procedure that verifies you're giving the right medication to the patient at the right dose. This has been found to reduce medication errors. So talk to your partner about what you're going to give. It doesn't hurt to show them what you're giving. That'll help reduce any errors. Here's the table I talked about. So this just shows all the things I just talked about, all the patient rights of medication administration. So these rights you will definitely see on tests in the future, and it's definitely something you're going to need to think about anytime you want to give a medication. As we move into doing the practical days, you're going to start doing medical assessments, and part of those medical assessments will be giving medications that you're allowed to use at your scope. When you're saying you're going to give those medications, whoever's going through that scenario with you is going to ask some of these questions. So this table is in your book, but that's definitely something you want to jot down and you want to remember. So over the years, EMTs have been allowed increasing responsibility when it comes to medications. Many departments have strict guidelines on when an EMT is allowed to administer a medication. Um, there's peer-assisted medication. You can administer medication to yourself or your partner. For example, if one of you was exposed to a toxic agent, you might be able to give your partner a medication, or you might even give it to yourself. Patient-assisted medication is when you assist the patient with administering their own medication. For example, if they have an EpiPen, if they have their own nitroglycerin, or if they have their own metered dose inhaler, you can assist them with their own medication. EMT administered medications are directly administered by you. The patient might even they might be confused, they might be unable to understand the need for the medication. For example, if you were going to give them oral glucose or oxygen. Medical control, state guidelines, and local protocols will determine when an EMT can administer medications. So for administering oral medications, you're going to need to take your standard precautions, meaning have your gloves on. You want to check the medication and confirm that it's not expired. If you need to call medical control before you administer it, make sure you do that. Confirm the patient has a patent airway and they're able to swallow or chew the medication. And then you want to monitor the patient's condition. All right, we're going to start going through medications. So if you're taking notes, this would be a good time to write some stuff down. We're going to go through all the medications you're able to administer at your level. And when we have our next practical day on the next Sunday, I will have a packet for you with a printout of each of these medications and some of the information. So the first one is oral glucose. So glucose is a sugar that cells use for energy. It's necessary for your brain cell survival. We use this to treat a condition called hypoglycemia, which is extremely low blood sugar. Oral glucose can counteract the effects of hypoglycemia. An EMT can give glucose only by mouth in the form of a gel. You should never administer an oral medication to an unconscious patient or to one that's unable to swallow or protect their own airway. Aspirin reduces fever, pain, and inflammation, and it inhibits platelet aggregation or clotting, which is useful during a potential heart attack. Some of the contraindications to aspirin would be a hypersensitivity or a known allergy, pre-existing liver damage, bleeding disorders, and asthma, and aspirin should not be given to children. Sublingual medications. Um, the advantages, it's easy to talk with an awake and alert patient to advise them to place the pill under their tongue. Absorption rates are relatively quick. And the disadvantages. Any medication placed in the mouth requires constant evaluation of the airway. And you would never use these medications for a patient that's uncooperative or unconscious. Nitroglycerin. Many cardiac patients carry fast-acting nitroglycerin to relieve their angina pain. It increases blood flow by relieving the spasms and causes the arteries to dilate by relaxing the muscles of the coronary arteries and veins. It also relaxes veins throughout the body so that less blood is returned to the heart, decreasing workload and blood pressure. So you can see on the right-hand side there, up on the top, you've got nitroglycerin in a spray form, where you'd actually just spray a squirt into their mouth. And on the bottom, you've got nitro tablets. So in that little tiny jar, there's actually little tablets in there. And this is one of those medications that you definitely want to make sure you have your gloves on. Nitroglycerin causes a very severe headache. And if you as a provider touch that nitroglycerin tablet to put it in their mouth and you don't have a glove on, you're going to give yourself one heck of a headache.
If I didn't have my glove on?
Oh boy, John Hatch. Welcome to the meeting.
I'm sorry, I just wanted to know about the glove.
So before you administer nitroglycerin, you want to check the patient's blood pressure. You want to obtain orders or follow your local protocols. And there could be a potentially fatal interaction if the patient has consumed erectile dysfunction medication within the past 24 hours. Some of the common medications are Viagra, Cialis, Levitra, and they can be used by both men and women. These medications can be used to treat other things. It's not just for erectile dysfunction. So you should always ask, no matter the gender of the patient. To administer this medication, you're going to place the tablet under their tongue where it's going to be allowed to dissolve. The patient's going to experience a slight tingling or burning sensation. And nitroglycerin should be stored in its original glass container with the cap screwed on tightly. You might have the meter dose spray like we saw in the photo. You're just going to spray that under their tongue. One spray is equal to one tablet. Considerations for both the tablet and the spray: wait 5 minutes for a response before you repeat the dose. Closely monitor the patient's vital signs, especially the blood pressure. Give repeated doses per medical control and your local protocols. Always wear gloves. Reconfirm if the medication is still indicated for the patient. Know and understand your local protocols. Intramuscular medications. Some of the advantages: that it provides quick and easy access to the circulatory system without the need for placing a needle within the vein. Blood flow to the muscles is relatively stable even during circumstances of severe illness or injury. And the disadvantages are the use of a needle and the subsequent pain. Epinephrine or adrenaline. This is something that your body produces naturally. It's a hormone that controls your body's fight or flight response. So the characteristics of this medication: it's secreted naturally by your adrenal glands. It dilates the passages in your lungs. It constricts your blood vessels, causing increased blood pressure. It increases your heart rate and your blood pressure. It should be given only to patients who are experiencing a life-threatening allergic reaction. And it can be dispensed from an auto-injector, or you may have to draw it up. A lot of services have gone away from the auto-injectors just simply because of the cost. So Ready Check Inject is a new program that a lot of places have rolled out where you actually draw the medication up before you administer it. The auto injectors will automatically deliver a preset amount of the medication, which for adults is 0.3 milligrams. Naloxone. Naloxone or Narcan can be used to reverse the effects of an opioid overdose. It can be administered by family members or caregivers. You should follow local protocol when you're using it. Find out if naloxone has been administered by a bystander prior to your arrival. Um, Anybody can get Narcan these days. You can go to the drugstore and you can get it if you have a family or friend that uses opiates. Um, a lot of police departments are carrying it as well. So before you give it, find out if it's been given yet. The effect of the naloxone may not last as long as the opiates. You may need to repeat doses. Administration of naloxone to opioid-dependent patients can cause severe withdrawal syndrome, which includes seizures and cardiac arrest. And you always want to consider safety when you're giving naloxone. The most common technique for naloxone administration is via the intranasal route. Oxygen is by far the most commonly administered medication in the pre-hospital setting. All cells, especially those in the heart and brain, need the oxygen to function properly. Generally, this is administered via a non-rebreathing mask at 10 to 15 liters per minute, or via a nasal cannula at 2 to 6 liters per minute. You must also provide artificial ventilations if the patient is not breathing, using a bag mask device at 15 liters per minute. And anytime you use oxygen, you want to ensure that there's no open flames, lit cigarettes, or sparks in the area. MDIs, or metered dose inhalers and nebulizers. They're used to administer liquid medications that have been turned into a fine mist by a flow of air or oxygen. The medication is atomized, breathed into the lungs, and delivered to the alveoli. The advantages, it's fast and relatively easy route to access. Disadvantages, the patient needs to be cooperative and control their own breathing. It can't be used for unconscious patients. A metered dose inhaler requires a great deal of coordination to administer, and it may be difficult to achieve when a person is having trouble breathing. One of the tools that we can use is a spacer. Some of the inhalers will come with that, and this allows you to better direct the medication into the patient rather than into the environment around them. Small volume nebulizers. They're much easier to use than an MDI. They do take longer to deliver the medication. They require an external air or oxygen source. They can be more effective than an MDI in patients with moderate to severe respiratory distress. They can be used while a patient is on CPAP and during bag mask ventilation. They can be easily adapted to a non-rebreathing mask. So your patient assessment is going to include finding out which medications the patient currently takes. This information is going to provide you vital clues as to the patient's condition. It may help guide your treatment. It may be extremely useful to the emergency department physician. It can help you determine a chronic or underlying condition when a patient is unable to relate to his or her medical history. You will forever have patients that'll tell you they have no medical history, but then list off 15 different medications. Um, Discover what the patient takes and transport the medications, or at least a list of them, with the patient. And you should ask about any non-prescription drugs, whether that be over-the-counter, an herbal medication, or an illegal drug. The implications for medical providers. Don't underestimate the importance of obtaining a thorough medication history. Medications are frequently not taken as they're prescribed. So just because the patient tells you they're prescribed a medication, you also need to find out if they're taking it as they're supposed to be. Um, Consider a patient's medication in the context of your clinical encounter. Patient medications may significantly alter the clinical presentation of many different acute medical conditions or injuries. So, a medication error is an inappropriate use of a medication that could lead to patient harm. And it's your responsibility to ensure that the environment doesn't contribute to the errors. Make sure you have good lighting, make sure your equipment is organized, limit any distractions as much as you can, and consider using cheat sheets to help you remember all the crucial steps of medication administration. If a medication error does take place, rapidly provide any appropriate patient care that might be required, notify medical control as quickly as you can, follow your local protocols, document the incident thoroughly, accurately, and honestly, talk with your partner, supervisor, or medical director. Take it as an opportunity to learn and identify any areas to target during quality improvement. So if you gave a medication because it's stored right next to a medication that looks just like it, you know, maybe to prevent this in the future, you could recommend that we move the medications away from each other to make it easier to differentiate.
Hey, JT.
Go ahead, Kevin.
Yeah, so one of the things that I always do with meds, and obviously with paramedics, we have a way ton more medications than EMTs do. I triple check every med before I administer it. And then I'm also showing my partner I'm giving this, so they also see it as well. That way, it reduces that chance for medication error. Because once you give it, you can't take it back, right? So that could actually be more detrimental to a patient if giving the wrong med for the wrong indication. And if you don't know something, you have protocol books for a reason. Look at your protocols, and then, like it says here, follow protocols. Look at the book itself, review it, and if all else fails, med control, like it says, call your medical director or medical control and say, listen, I want to consult with this, and I want to be able to give this medication. Do you feel it's the right time for it? And they'll either tell you yes or no. So you always have that backup to be able to, talk to somebody of a higher power to say, hey, can I do this? Can I not do this? Until you start feeling more comfortable with your scope of practice that you have. Even as an EMT, New Hampshire, Maine, New Hampshire more, there are a lot of medications you could administer, and some of them can be detrimental to patient health if given in the wrong time. So know your medications inside and out, and you will be covering these more as we get more into like cardiac, respiratory. You'll cover like albuterol, MDI inhalers, things like that you can do at the EMT level, especially utilizing with CPAP and things like that. We'll talk about more of that later, but um, double, triple check meds before you administer them. Please do that. All right, that's all I had, JT.
Like we talked about, that goes back to the rights of medication administration, making sure you're giving the right medication at the right time. Part of that is making sure that you're actually giving the correct medication. And like Kevin said, double and triple checking. You can't check too many times when it comes down to this. You can have some pretty serious side effects giving the wrong medications. Kevin, we're at the point of review. Do you have anything overall to add before we go through the review slides?
Not really. I've been in and out doing CQI, so like JT had mentioned before as well. I mean, quality assurance is huge, and I do all the reports here at work. So I'm currently reviewing calls from today from Massachusetts. So um, we do look at them, and any station you work for, department you work for, does do usually in-depth quality assurance stuff and quality improvement. I'm sure JT touched a lot on that. That's how we make things better, how we prevent bad things from happening. Like he mentioned, if we put the same medications next to each other, but they're different meds that can cause detrimental harm, can we separate those so they look alike? And that's part of the quality improvement versus quality assurance. So you got to do both of those together. They got to go hand in hand. So that's really all I had for you. I kind of, like I said, I missed some of it earlier, but um, JT's right. Just pay attention to what you're giving and know your meds, because there are contraindications, indications, side effects. Everything we do has a cause and effect, and we want to make sure we're getting the right effect that we're looking for this patient. So if you give, for example, really quick, and I guess probably want to get out of here early tonight, if you give somebody albuterol, you expect to see that it's a sympathomimetic. So you expect to see heart rate going up. It's an expectation since it's a sympathomimetic medication that also causes bronchodilation. So you expect the bronchioles to get bigger to allow for more gas exchange. And and these are all things that this is EMT level knowledge I'm talking to you guys about, which we'll cover during the respiratory section on the medication when you learn about it. But you have to understand the ins and outs of every medication that you administer. Don't do it because protocol says so. Do it because you know what the effects are going to be. Take that next step. Learn the medications you're giving. Understand what nitro does. Understand what aspirin does. Understand what albuterol does. What Tylenol, Motrin, all the different medications, Narcan, Epi, auto injectors, or where you check inject kits when you're doing intramuscular injections, what Epi is going to do, what do you expect to see, what kind of effects you expect to see with it. So that's why you talk about pharmacology. This is one of the most important things you're going to deal with. And if you have that unresponsive patient, you find a med list. Understanding the basics of pharmacology will give you a pretty decent history on what's really wrong with them as far as the medical conditions go. So understand pharmacology. I can't stress that enough. But that's all I got for you. Anybody has any questions for me at all? No? Everybody good?
Thumbs up if
All
you're
right.
good.
Thumbs up. I see a lot of thumbs up. Awesome. Oh, there's Kyle's thumb. Remember that we have class on Sunday, CPR, 9 o'clock.
All right, let's run through the review real quick and go from there. Pharmacology is defined as what? Very good. B. Pharmacology is the field of science that deals with the study of drugs and medications. The following statements regarding medications is false. Very good. C. Which of the following routes of medication administration has the fastest effect? Good. B. So remember, intravenous medications are going right directly into the vein, so they get into the circulatory system the fastest. When administered to a patient, a metered dose inhaler will do what? Very good. A. Metered dose inhaler delivers the same dose every time it's used. We're managing a 62-year-old woman who complains of crushing chest pain. Her blood pressure is 84 over 64. Her heart rate is 110. Medical control advises you to assist her in taking her prescribed nitroglycerin. After receiving this order, what should you do? All right, we're a little skewed on this one. The answer is B. Repeat the patient's blood pressure to the doc and reaffirm that they still want you to administer the medication. So, nitroglycerin is a vasodilator, which means it lowers your blood pressure. We don't give it to patients who has a systolic blood pressure less than 100. This patient was less than 100, therefore they do not qualify for nitroglycerin. Even though the doctor told you to do it, you still have the patient's best interest in mind when you reaffirm with the doc the blood pressure is too low for nitroglycerin. That's where you've got to be a patient advocate and speak up to that. Activated charcoal is indicated for patients who have ingested certain drugs and toxins because it does what? Very good. D. It binds to the chemicals in the stomach and delays the absorption. With regard to pharmacology, the term action refers to what? Very good. D. The affected or the expected effect of a drug on the patient's body. Which of the following patients is the best candidate for oral glucose? All right, very good. A. So this is one of those questions that, like we talked about with the National Registry exam, they give you questions with slight little differences to trip you up. So A and C were very similar, with the exception of A being hypoglycemia and C being hyperglycemia. So oral glucose treats hypoglycemia, which makes A the correct answer. May have just given that one away. I apologize. Epinephrine is given to patients with anaphylactic shock because of its effect of what? All right, we were a little skewed on this one. The two major complications associated with an anaphylactic shock are bronchoconstriction, which impairs air movement in and out of the lungs, and vasodilation, which causes a drop in blood pressure. Epinephrine reverses these processes by causing bronchodilation and vasoconstriction, thereby improving breathing and increasing the blood pressure, respectively. The answer was B. The process by which medications travel through the body tissues until they reach the bloodstream is called what? Very good. C, absorption. All right, we made it. Kevin, do you have anything else?
Nope, I'm all set. Should be good. I'll have the quiz posted for 10 o'clock tonight. I'll run for 1 week. And I believe, if I remember correctly, I had to look at the syllabus. Stand by a second here. I think you guys have your first exam next week. Yeah, March 30th. So you guys have your first exam next week. So every chapter from the beginning of class, so I'll just read these off to you really quick. You guys you'll have an exam. There are 100 questions. Chapters 1, 2, 3, 4, 5, 6, 8, 10, 11, 12, and 13. So you'll have an exam on that. You get one chance. The exam opens at 8 o'clock in the morning, closes at 6 o'clock at night. And then at 6 o'clock, JT will start your lecture. All right, so you can log in anytime throughout the day, take the exam. If for some reason you are working and you cannot take it, you need to email me directly and let me know what's going on so I can make some arrangements to have you take the exam either maybe the night before or the day after or whatever it may be, just help you get it done. But it's open from 8 to 6. Any questions on that? No? I'm going to send out emails as well to remind people. Some people aren't in class and I do the family emergencies. So I'll send an email as well as a reminder.
All right. Anybody have any general questions? Thumbs up if you're good with no questions. All right. Perfect. Well, you're good to go for tonight. Use the extra time tonight to read through your book and do some of the activities on the platform. Have a good night, everyone.